Mute yourself as well. Mute.
Hello, Barbara. I'm just fiddling around with some stuff, so I'll just disappear and rejoin in a moment. But we should be open, and the other account is held by Teresa temporarily.
It says Aruna Mehta. You see this?
Oh, one second.
Yes, it does.
Hang on, don't panic. What happened here? No, this one. You want this one? Okay. Make this screen bigger. And sorry.
Okay. All right.
1 minute and just check. Where's your
Yes, Peter. Okay.
Morning, Aruna. We're just getting it ready.
Good morning. I'll mute myself again.
Can they hear you? Check if they can hear you.
Can you hear me, Barbara?
Yeah, we can hear you, Aruna. We can hear and
Excellent.
see you fine.
That's great. Thank you.
Doesn't have us both down as host or co-host.
That's weird, isn't it? Oh, I'll make you host.
Mute.
Hello everyone. Hello Barbara. Hello Pat.
Your video starting.
Okay. Hello Sue, everybody. Very nice picture of Ruth's. Is that Ruth's handbag we can see?
Video.
Hi, John. I'm just about to join the board, but yeah, okay. Yeah. 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 He said what, sorry? It varies the consistent, okay.
Barbara, Peter, Derek is having difficulties finding the link. And he's asked if somebody can help him.
It's been resent to his university address if you're in direct contact with him. I'll ask Teresa to resend.
Okay.
Good morning, all. Can we hear? Morning, Elizabeth.
Hello, Phil. Nice to see you. We're just
Hi.
trying to find Derek, who has lost his link.
Oh, right. I'm sorry. I was just checking my thing was working. That's all. That's good.
Yes.
It sounds like
Yeah.
it's all working well.
We had an amusing experience when the first time we did it like this. Somebody couldn't get in, so Aruna very kindly shared her link, which meant they came in as Aruna, but she couldn't then have access.
Yeah, it can be difficult when because there are certain controls on these things, which mean that sharing isn't necessarily allowed. So
Yeah.
Guys, is Peter around? Is Peter on the call yet? Because Derek's struggling to get in. He doesn't seem to have a link.
Hello, Gillian, it's Meg. We've sent a link.
Oh, thank you, Meg. Thank
Just
you.
sent a new one.
Meg, can you turn your mute? Thank you. Just to remind everyone, we are live, so we do have members of the audience already with us. So just to remind you and to everyone that we will be starting once everyone's assembled. So bear with us whilst we sort out any of the technical difficulties we have, just to get the whole board assembled. So please be patient.
Thank you very much indeed, Peter.
Meg, Barbara, I think I think Derek is still having problems. He's only got the link for this afternoon, he says.
Elizabeth, we've just sent it to him just about 3 minutes ago. He needs to look in his emails.
Okay, I'll tell him that.
Okay.
I've just messaged him to that effect. Elizabeth, if you're trying to do that as well. I was typing it as you were talking.
You're quicker off them with your typing than I am.
Well, I think, Elizabeth, you were talking. I had the advantage of listening to you and typing at the same point. Peter, it is 9:30. Are we good to go, do you think?
I think he was just trying to support Ruth. Hang on, let me see if I can find him.
I just
do it like that.
Yeah.
Right, thank you. Sorry, don't.
Looks as though Derek's in now. I think perhaps we're all here, are we? Just let poor Peter, for whom this must be the most stressful of times, get to his desk.
I was just helping Ruth get set up.
Thank you, Peter. As Peter knows, I had the most awful experience trying to get into a seminar at South West London St George's earlier this week. which sent me into a complete, this cannot happen for a board. And Peter had to actually run a test with me on Wednesday to restore my confidence. This technology is wonderful when it works, but it's quite stressful when it doesn't. Anyway, I think we're good to go. So a very warm welcome to all members of the board and members of the public who have joined us for today. I believe we have our CQC, one of our CQC officers with us today, called Renee Claus. I haven't actually had the pleasure of meeting Renee, but welcome nevertheless. And I'd particularly like to say Happy Diwali to all our staff members who, for whom Diwali is their big celebration, and everyone in our community. This is a very special weekend, and it's going to have to be celebrated in a most unusual and uncomfortable way, I think, because of the lockdown. But we all understand that, and I'm sure people will be doing the best they can. I was just reflecting overnight how I would feel if we get to Christmas and it's the same. So I think our thoughts are very much with our colleagues and communities for whom Diwali is such a big celebration, and hope that they enjoy it despite the circumstances in which we find ourselves. I don't believe we've got any apologies for absence other than Rakesh, who has had to go to a very important system finance meeting. And much as we want him to be here, I think it's in our best interest that he's there, but he will join us as soon as he possibly can. So he may suddenly appear at some point, and that's the reason. I think Chris, have you, is Chris with us? Chris may have to be in and out.
Yes,
Chris, you're here.
I've just joined. Thank you very much.
That's terrific, but because of family illness, it may be that Chris might have to dip out at some point, and if that is necessary, we will entirely understand, Chris, and wish your family the very best. Right, so I think we can move on to 1.2 and declarations of interest. Are there any declarations that need to be made? No, thank you very much, everybody. Turning to the minutes of the previous Board of Directors meeting under item 1.3. Can we agree those minutes? Thank you, everybody. In relation to the chairman's update, I only really want to mention one thing, because some of the things I would have mentioned are in Daniel's report, and there's nothing worse than your chairman stealing your thunder. I've got no intention of doing that. But I would just like to tell you a little bit about a visit I did an Epsom hospital, actually, about 3 weeks ago now, with Philippa. And we went to day surgery, diagnostics and the records office. And it was a most inspiring visit because I met so many staff who are going that extra mile to make sure that our planned care really gets up to the levels that we want it to, given the events of earlier this year. And it was so energizing. It was humbling, actually, but also energizing to see just how hard our staff are working, including somebody who had been shielded, a key member of the day surgery team who'd been shielded, but was back at work. And talking to her just reminded me of just how difficult it has been, in particular for some staff. It's been difficult for all staff, but for some it's been even more difficult. And I wanted to pay tribute to all those staff that I met and all our staff who are working so hard to look after COVID and non-COVID patients. And I think they're doing an absolutely fantastic job, and I'm very proud of them. That's all I wanted to say by way of my update. Daniel, item 1.5.
Thank you very much, Gillian. So my update. Well, the really exciting news, I think, for us is that the process by which we can build our specialist emergency care hospital and upgrade Epsom's and Helier sites has now finished. So we've been through the CCG consultation process. The CCGs have made a decision, and the Secretary of State, having taken advice from the independent reconfiguration panel, has now concluded that the decision that the CCGs have taken on the location of the Specialist Emergency Care Hospital at Sutton is appropriate. So it is now full steam ahead for us to submit the business case, which we're aiming to do by the end of the calendar year, to draw down the funding so we can go out and appoint a builder. And the plan will be for the contractor to be on site in Sutton in the early part of 2022 to start work and have our new specialist emergency care hospital open for 2025. So that is I think the most or the biggest news in the month in my report. There's quite a bit in my report about COVID, but the next agenda item is about COVID. So I don't think I'll say very much about it, other than echo Gillian's thanks to everyone in Epsom and St Helier for really working extraordinarily hard to look after now quite a lot of COVID patients again, more than 80, as well as deliver, we're back to 100% of our business as usual levels for all of the planned care services. So extraordinary team effort to make that happen. We were given some money to invest in another CT scanner at St Helier. So we now have 3 CT scanners on site, and they're all open and staffed and caring for patients. So there's a photo of the opening of the 3rd one. We've decided to start making some videos of some of the most amazing people who work in Epsom and St Helier, called Humans of Healthcare, where they tell their stories. So Pat Mendonza, who was featured in the photo, so she has been at St Helier for 38 years, I think, and she retires at Christmas, on Christmas Eve. She is quite an extraordinary character and fantastic nurse. So it was great that she's made a podcast of her own experiences. We have done lots of celebrating in the last few weeks. We celebrated Black History Month, and we launched our Women's Network, where Gillian made one of the star turns, along with Alan Siraj, our head of education, who talked about his life. And then lastly, we launched during the first COVID wave a scheme called Letters to Loved Ones, where we facilitate communication between the patient and the relative through the conventional thing called a letter. And we've had some lovely feedback about that. So we shared that with hundreds of letters have now been created by relatives for patients as part of that. And that's clearly in addition to the FaceTime and the using iPad visits, as well as the real face-to-face visits, which we are making happen wherever it is possible. So there we go. Quick snapshot of life in Epsom and Helier for the last few weeks.
Thank you very much indeed, Daniel. Are there any questions from board members for Daniel? I'm sorry, Peter, I can only see 9 people on the screen, and if I go to the participant list, it still takes a while. So if you can see anybody that I can't, could you give me a nudge? Thank you. Right. I think Peter's saying that there's nobody, so I'd rely. That's right. I'd also rely on you guys to shout out if necessary, but not in an uncontrolled way. Thank you. Thank you very much for the update, Daniel, which we note. That will take us on then to item 2 on the agenda. And the first item is the COVID-19 update. I'm not sure whether it's James or Ruth who's going to start. I'm sure Arlene will have something to say as well. So it'll be a bit of a team effort, but I think that probably means from that short intake of breath I heard, it's going to be James who starts.
It's Ruth. James actually.
Oh, sorry.
So it's a Ruth. Sorry, Ruth. It's a Ruth and Arlene double act today. So a short update on COVID. As you will be aware, we have seen the evidence of COVID in the community and the prevalence increase over the last few weeks. And that's been reflected in increased activity in our hospitals. As of this morning, we have 83 current inpatients who are COVID positive, which amounts to 13.9% of our current inpatients. Consequently, we have, as we have been planning over the last few months, incrementally increased our capacity on intensive care and have increased the number of beds available on the St Helier site by enacting phase 1 of our redeployment plan. So as of this morning, we have 14 beds open at St Helier. But the important thing is we have 3 empty beds in ITU at St Helier, and we're working very collaboratively across the system and the network to ensure there is adequate capacity. Our oxygen usage, as you know, is being very closely monitored, particularly on the St Helier site. And over the course of this week has been running, I think, between 60 and 69%. Staff sickness, whilst impacted by COVID and other non-COVID reasons, is running at 4.73%. So I think slightly down from where it was about 2 weeks ago. And then some very exciting news that today we start the process of asymptomatic staff testing, which Arlene is leading on, using lateral flow tests, which is a very positive development and step forward. And also, whilst launching that, are planning how we will ensure we are fully able to mobilise to ensure our staff and local community can receive the COVID immunisation when it becomes available at the beginning of December. Meanwhile, important that our elective activity, as Daniel has already referred to, carries on with 100% plus of business as usual activity in both outpatients and also across the elective surgical specialties, but showing evidence of innovation and change in practice, with 40% now of outpatient consultations being remote rather than face-to-face. So that's a very quick synopsis of our current position that relates to COVID, and Arlene is, I think, going to focus on infection prevention control and the nosocomial issues that we have encountered.
Thank you very much indeed, Ruth. Over to you, Arlene.
Thank you, Chair. Good morning, everybody. So there is a report that we have included in the papers on nosocomial infections. I just wanted to highlight that we have had a few outbreaks, so 3 outbreaks of COVID in the organization involving patients. These outbreaks were renal ITU, both areas, so started in renal, and we recognized through contact tracing that the patient had gone to ITU, and so we tested everybody there. I think it's important to highlight, as the paper says, that nosocomial infection would be considered to be an infection that a patient didn't have when they came into hospital, but developed later. So for Epsom and St Helier, and I think, you know, it has been in the national press that we were an outlier. Largely, this is based on how it is measured and presented. So if we do the last 7 days, for instance, if you're in the middle of an outbreak, your prevalence will be high because you've got large numbers or comparatively big numbers compared to the patients that you have in hospital, and therefore it will be it will look as if you have a high rate of nosocomial infections. This is we monitor this internally, and we have a weekly report that tells us where we are, and we continue to work to ensure that we're not our rates are within the range that we would like, which is quite low. I think important to say in this report as well is that on page 3 and 3, thank you, of the report to one of our NEDs, point 1, it says that a significant proportion of cases identified at 8 days or more after admission were asymptomatic. So, and these patients typically had and it should say negative, not a positive test on admission. So that's what we found. All of our patients are tested on admission, and most of the cases that we then picked up when we tested them, either because they were a contact, and quite a number of them was because they were going to a nursing home or a placement, which were required to test, were then found to be positive, which would mean because of how it's counted, as in anything under 8 days, under 8 days is considered to be not hospital acquired, but 8 days and beyond is considered hospital. So that's where we are. And just to say that we are continuing to monitor it. The report it gives detail around the actions that we have taken as well, and continue to take, the learning that we gathered from investigating the outbreaks, and we will continue to do those and apply the learning. And I'm happy to take questions. It is quite a detailed report. So.
Thank you, Arlene. It is a detailed report, but necessarily so, I think, given the importance of this. Questions or comments from colleagues? Aruna, yes?
Arlene, could I get 3 outbreaks. Could I ask, do we know how many patients were actually affected? And if so, do we know the demographic of these patients?
Yes, we do know the numbers. I don't have them off the top of my head, but the numbers are tracked by infection control. So if I was to speak to one of the infection control nurses, they'll tell me exactly how many patients. And if I spoke to occupational health, they'll tell me how many staff. So we do track those numbers, which I can provide. In terms of demographics, yes, we also have that data because it is also included in any of the testing and reporting that we do. So we have all of the data, which includes ethnicity and all of the other data that you points that you would think we should have.
Yes, I mean, I know your report says that there is no significant difference between the tests that were used, but it would be good to have a look at the patients, if there's a finite number of patients, what test they were first subject to, and then what the follow-up test was, just to get some clarification in terms of whether it was the sensitivity of the test, and also possibly the movement and the trajectory of the patient through the hospital. But we could do that in PSQ. I just thought it would be an interesting thing to look at.
Yeah, so for every outbreak, we look at each patient affected and we track their journey. So that is also available as to where they started and where they were found positive, where they were on day 1, day 2, day 3. So it's quite a detailed process. All that data is available.
Okay, well, perhaps we can touch on it at PSQ. Thank you. Thanks for that.
Thank you, Aruna. And I know PSQ did spend a lot of time on this subject and necessarily so. Derek, I believe you've got a hand up.
Yeah, thanks. Thanks, Arlene. I just wanted to flag up a couple of things. I just think this is a really detailed assessment. I know the renal outbreak had a lot of high-level governance from a lot of external bodies, so that was really well overseen, in my opinion. And I think just wanted to flag up, the problem here is partly physiology rather than testing, in the sense that, and you've really highlighted this very clearly in the report, but I think it needs re-emphasis, that you can come in with no symptoms and a negative swab, and the next day you've got virus in your pharynx, and that's nothing to do with a false negative. And I think you're very wise. There's this question about whether this is carriage or not. And your point 1, currently these are being classified as infections. And I think you have to carry on doing that. And I think that's very wise to carry on. I think carriage of virus is a very difficult concept, because to get virus, you have to have replicate, you have to have new viruses being made. So I think that's very prudent and wise. And I get, if you took this to an absolute theoretical absolute, you've got to retest people every day, which clearly isn't feasible. But the sort of repeat testing date, that's from national guidance, isn't it? 5 to 7 days.
It is.
Do you see that moving at all, or do you see us locally feeling a need in certain circumstances to add in earlier repeat testing? So for example, if someone was going to have surgery, would we do a repeat test 72 hours before the operation, even if they hadn't reached their 5 to 7 day time point?
Yeah, so I think if they're an inpatient and they're going to have surgery, of course, these are all, inpatients in the emergency pathway. The patients who are on the elective pathway are tested, in advance anyway, prior to coming in, and they have symptomatic checks. But if a patient was going to have, going to theatre and they are in the emergency pathway, I mean, we will always treat them as positive anyway. So we would, because they are in the emergency pathway, so we wouldn't say, for instance, you would take them to theatre and use just normal PPE if they're being intubated and all of that. So have we considered testing them in less than 7 days? No, we haven't. I'm not sure what the benefit of that would be. We have put in measures to ensure that they are tested definitely within the 5 to 7, which includes flagging that they are coming up to their time to be tested. But I have to say that quite a number of the patients that do then go on to test positive are actually patients that are being discharged or have been in hospital for more than those anyway. So yeah, it's something that I can take back to the group and we can think about.
I think this is really thorough and you've shown a great deal of insight, so thank you for that.
Thank you, Derek. I've got Martin and then Pat.
Arlene, thanks for such a comprehensive report. Can you tell us anything about the latest plans in terms of staff swabbing?
So staff swabbing, I think as Ruth mentioned, to date we have been doing symptomatic staff using PCR testing. So we have a process set up, a staff member becomes symptomatic or their loved one. So anybody in their household, we are also testing those so that we can keep staff, support staff to stay in work or not, if that's what is required. So they apply, send an email to request a test and they come in, they have a test, is done, drive through on the St. Helier site of Malvern Centre. And so that's in place. We our first wave, it's what is being called now for the mass testing, which would test asymptomatic staff, and that starts today. We became aware of it at the weekend, and we've had this week to sort out the guiding principles and to get the governance right. I think we have had delivery of the first set of tests, which would enable us to test 54 staff. So the way that works is each member of staff is given a box of 25 tests to take home, and they test themselves twice a week. So, you know, day 3 or 4, the first day and then day 3 or 4. If the member of staff tests negative, then it's fine. They just continue their normal testing. If they test positive, then they send an email to apply for a PCR test. We will do that test. They need to isolate, self-isolate while they wait the results of that test. If it's positive, then they go on to isolate for 10 days and their family members for 14 days. If it's negative, then they can come back to work. But if they have a positive on PCR, they also stop the self-testing for 90 days. And that is in keeping with the Siren study that we have going as well. So the plan is that we start today and we roll it out across the organization.
Thank you.
I think Pat has told us all here via the chat room that was exactly her question, to which my response was great minds. I think I can't see any other hand. I can't see any other hands at the moment, Arlene. But I think it's fair to say that this the setting up this staff testing thing must have been the most enormous logistical and governance task for you all. I can only begin to think about some of the areas you've had to cover. Is my assumption correct?
So I think when we were doing this symptomatic staff testing, it took a while, but we managed to get the governance and the process right. My hesitation around this mass testing this week has been because the national process said that we would have to get staff members to write the results on a bit of paper that they then return to us to put on a spreadsheet. And I just was not prepared for us to do that. We also didn't get the SOP until late on, or we were told we would get it on Monday. It didn't happen Monday or Tuesday. It eventually came on Wednesday. It's quite strategic, and we needed then to ensure that we had a process that we would be able to adhere to internally, and so that we had the governance, because these tests are being used off license as they were currently, but we have national cover for that. And so, yes, it has been quite a big task. And when we start, we will, you know, kind of have a feel for how much more, what else we need to do. But we have our IT team have been very good in helping us to set up an electronic way to capture the results so that we don't have to do the little bits of paper for our 7,000 staff.
I'm mightily relieved about that, Arlene. I asked the question because I was in a national call talking about the fact that there was no portal for this. And the kind of unsaid bit of it, because they ran out of time for questions, was that their trusts were just going to have to sort something out, kind of thing, which was really my reference to the kind of logistics and governance elements of this. Inevitably, people see that this kind of thing is happening and feel very relieved, as indeed we are. But the additional tasks that it imposes upon an already exceedingly busy hospital should not be underestimated. So thank you very much indeed for that. I can't see anybody else has indicated that they want to ask a question or indeed offer a comment. So my thanks to Ruth and to Arlene. If we could note the report, the verbal report from Ruth about the current state on COVID and the written report from Arlene on nosocomial infections. Is that okay? Thank you. That enables us then to move on to the reports of the subcommittees, and we will start with Patient Safety and Quality Committee. Pat.
Thank you, Gillian. So there is a report which is quite lengthy, so I'm not going to go through every item on it because this is two long meetings that we've had with over a very busy period for the Trust. But as you will see and expect, the two meetings in September and October had significant discussions about the situation with COVID, which was then the second surge was building up, and there were a number of issues that we were asking about and which were reported on, including fit testing, because fit testing for the staff for their PPE has to be redone if there's a new mask that is brought in, and that is going to happen if it hasn't already happened. I'm not sure whether we're actually there yet, but that a little bit like the testing we've just been talking about is a major task. So we were reassured that it was all ready to go for the new testing. There's also the oxygen supply, which has been referred to, which was is on our risk register, and we have had some good news that we are more likely to get this in good time than we thought at one of the meetings. However, with the second surge in place, we are at the moment, the last meeting we had, January was when this would be the new supply would be start to be provided. So there is still the necessity to monitor the usage very carefully in the wards, particularly with COVID patients. There's still a concern about that, obviously, until it's completed. We were very pleased to hear, though, that we were part of a research trial with St George's for vaccination against COVID-19, which maybe we'll hear an update on later how that's going. We had the management of the outbreaks that we've just been hearing about, which we were very pleased how they've been handled. I mean, clearly they're not good in themselves, but the way that they've been managed, we had substantial assurance that was being done both adequately and with a lot of input from our partners and stakeholders, which gave assurance that everyone was playing their part and assisting with it and learning from it as well. We yet again had a discussion about the situation with CAMS, where we have limited assurance that on this situation where young people are coming in and we cannot, particularly on the Epsom site, find them beds in suitable placements for their mental health difficulties. This is really not something that is within our gift, but it is something which we have to manage, and I would like to pay compliments to the staff who are handling some very difficult situations over the months that we've experienced this situation. And we will be pressing, and all we can do in the committee is supporting the exec team to press for a solution at a sector and national level, because the way these children are being provided with care is not the way it should be. We had a very encouraging report from on the progress at the Mulbridge practice, which is the GP practice in Surrey, where we took over in October last year, so just over a year ago, and huge progress has been made. We got really significant assurance about the way that the practice and the patients that have been loyally attending the practice, despite perhaps a lot of leadership gaps over the last few years, are now getting a much better service, and that service continued through the COVID situation in the spring. And I think leadership has been key there to produce that beneficial effect. Very pleased to have substantial assurance on the management of our IT issues, where we had on our risk register for a long time the problem of outdated IT, where we were getting failures and we couldn't repair them in a way that was gave us assurance that that everything wouldn't crash. It was put off from March, but took place in September. Everything was shut down and the system was overhauled. I'm not technical, as you can tell from the way my language, but it all went incredibly smoothly. And again, I would like to compliment the whole team and the whole trust, because everybody had to have some part in this, in the way that it went smoothly. And now we have really substantial assurance that not only can we manage small things that go wrong without having to jeopardize the whole system, but the system is now a great deal more resilient. At our request, we had a deep dive into the maternity caesarean section rate and the CTG readings, not because I would like to say because we are outliers in any way. In fact, our performance is very good when compared with benchmark trusts. But we had a couple of SIs where we wanted to know whether there was anything more that should be done. And we received substantial assurance about the process of monitoring and investigating afterwards, and the fact that the caesarean section the increase of caesarean sections was actually due to identifying smaller babies at an earlier stage who might then have difficulties when born or indeed at birth. So there were really good reasons, and indeed that's the national picture. So that was very reassuring to us all, because clearly these are the neonatal care of our patients is incredibly important to us. We had the infection control annual report, which I believe is on the agenda this morning, which all I would observe is that we look forward to the continued focus on antimicrobial stewardship, which is something which is extremely difficult to balance again, sepsis rates and the need to make sure that we have them kept under control very quickly. And then we had we will be having a report at the next meeting on the fundamentals of care, which covers pressure ulcers and falls, because this is the sort of issue on wards on a daily basis that need to be maintained at a high standard. And there is a new team that has been brought together by Arlene, and we are waiting to hear the results of that team and to look forward to hearing that it is making a real impact on these fundamentals, fundamental being the operative word. At this stage, we have had a few falls that we were concerned about in the SI reports, and that's why we've asked for this presentation, which we're getting at the next meeting. I think those are the main points from a quite detailed report, but obviously if there are any questions for me or for Ruth or other members of the committee, I'd be happy to take.
Thank you very much indeed, Pat. As you say, two very heavy agendas there. I haven't so far seen any hands in relation to your report. So I wonder if I could ask a question, and well, that might give people time to think. And it's probably one for the executive, Pat, rather than you. I just wondered if there was any change in the January date for the work on the oxygen supply. We know how important that is, and I'd be very unhappy if that were to slip. So could somebody confirm or otherwise that we're still expecting it to be resolved in January?
Trevor will be able to be most up to date, but January is still the date. And there was a call last week that Trevor took part in trying to bring forward that date with sector-wide support for it to be done before January. But Trevor may have a more up-to-date position.
Thank you, Ruth. Trevor?
So we are still at the moment working towards the date of mid-January. We are trying to bring that forward, and we do have the support of an HSI&E estates oxygen capacity sector working with us. And there's a three-way meeting today with BOC and NHS EI and the Trust to try and work through getting an earlier date to increase that capacity. So I'm hopeful that everyone understands that we're increasing our usage and the urgency of this. It's just around BOC in terms of the amount of work that they're having to do in terms of oxygen capacity across the whole of the UK that they're struggling with. But they do see it as a priority. So hopefully early next week we'll have more firmed updates.
Thank you, Trevor. That's very helpful. I mean, I do understand their problems, but my particular worry is us, actually. So, some small reason for encouragement there. I still haven't seen any hands, so I'm indulging in Chairman's prerogative, which I'm not sure I wholly approve of. But there you go. Is there anything else, Pat? You referred to the CAMS situation on the Epsom site. It's just so wrong and unsatisfactory, isn't it? Is there anything else we can do as a board, does anybody think, to highlight just how unacceptable this situation is? Sorry for throwing that one in, but I just...
Daniel's got it. Daniel, I think, might. I mean, I know that the execs have been speaking, at high level about this, but Daniel.
I know. I just wondered if a kind of board discussion and board minute could help in any way. Certainly at George's, we on a very different subject, we did get some movement on a key issue through doing that from board. Daniel.
So now I sit on the Surrey Heartlands executive team. With the Surrey Downs hat on. I know that this is really, really high up the register of things that Surrey as a system are very concerned about. And I think next week there is a summit to talk about mental health as a whole in Surrey, involving all of the agencies. So I'm confident they understand how important it is to resolve this issue, because it's not just us that has the impact in Surrey. I think all of the acute providers have the same problem.
I mean,
Daniel.
It is so important, because I mean, there are going to be far more cases, one would expect, after the period of COVID. I mean, mental health is going to be a real issue, and if we can't do it for our young people, I really don't know what we're doing.
Yeah. So on the London call last night that Sir David Sloman organises of all the providers, the Mental Health Trust did a presentation, and they said that exactly what you just said has happened, Pat. During the first wave of COVID and lockdown, referrals went down hugely, but presentations since the summer have gone up absolutely massively, and there's a huge amount of extra resource required to look after a lot of very vulnerable people.
Well, I'm glad, Daniel, that Surrey have got it at the top of their risk register, because it's just the most awful situation for young people and their families, actually, and we're storing up such awful problems for society. But anyway, this is descending into collective hand-wringing, or chairman hand-wringing anyway, which is never very helpful. So I've still not seen any hands.
Raised his hand.
Oh, Chris, thank you. Thank you, Peter.
Thank you. Yes, no, really just to reiterate everything that's been said, particularly at the Surrey end on CAMS, and I would hopefully Daniel or someone will be able to bring us an update at our next board meeting. And I'm sure, I would imagine Pat will want to hear as well at the next PSQ how it's going on, because certainly I feel it's very strongly that this is an unacceptable performance particularly at the Epsom end of things, even though there's pressure across the thing, but that's a particular problem for us. Thank you.
It's on our agenda every meeting because it's just not resolved.
Yeah, thank you very much.
Thank you, colleagues. For me, because we're responsible for a whole trust, I always get particularly uneasy when I see differential outcomes or treatment for people between the two hospitals because they're in different ICSs. You've heard me say that in relation to domestic violence and the IDFA support as well. If there are no further questions, thank you, Pat, for that. Can we know? Oh, Sue, did I see?
Ruth.
I think I've. Thank you, but I've also seen Sue, unless
No,
she was trying to tell me. You were telling me it was Ruth.
Yeah.
Thank you, Sue. Ruth, sorry, I didn't.
If I may, just for those that haven't been close to this issue, I think it's probably important to note that the specific issue that we're discussing is the availability of Tier 4 inpatient CAMS beds for the sickest young people. So very clearly, we've done a lot of work with the local mental health trust to make sure that we can cater for those that have a very short-term need for assessment and admission. But there was a very specific issue here relating to Tier 4 bed availability. So just a point of clarification.
Thank you, Ruth. It's helpful that you remind us of that. But it's that particular reason that I feel so anxious about it, really, because these are the most vulnerable of our young people. So if we could note that report, I can't, flicking through the participants list, I can't see any other hands. That takes us on to the People and Organisational Development Committee report. Aruna.
Hello, everyone. Thank you. So at the People and Organisational Development Committee, we spent quite a lot of time actually on staff appraisals because we think it was really important to make sure that our appraisal system now lines up with our philosophy of respect, really, our value of respect. And so, you know, very focused on the successes, struggles, set goals and support to make this more effective and align with our values. So the team has taken that away and is going to work with this new concept. And I believe it has been piloted. Gillian, if I'm right, I've been told that you have already piloted it. So I feel very, very confident that this is the right way forward in terms of making sure we get the best, from our staff, and they deliver their best, and we set them up for success, really. We spent also quite a lot of time, really, I guess, quite obviously, because on staff health and well-being and freedom to speak up Guardian, at this time, that is of our paramount concern. I certainly, and I think the group certainly felt very assured that we were certainly doing everything we possibly can. And I would say that I've sat in on quite a lot of network meetings and team meetings where staff have been allowed to openly air how they felt and have really been supported. And I think Arlene and Debbie have been instrumental in sort of taking that agenda forward. So it says moderate here, but I have to say I feel it probably leaning towards very, very good assurance, really, in terms of the way we're looking after our staff. In terms of people strategy, this is very much work in progress. The overseas recruitment, we had an overseas recruitment report from Arlene in terms of what we did in the past. We will continue to do that. It's been very successful, and the retention rates on our overseas recruits has been excellent. So we will do more of that. But what I will do actually is we're doing far more on the recruitment than is in this report. So if I may just for a few moments hand over to Debbie to just talk to the group about recruitment and our new recruitment strategy and attraction campaign. Debbie, would you mind saying a few words?
Thank you, Aruna. Yes, just in terms of the overseas recruitment, it's worth noting that Arlene and her team have been successful in the bid for national funding to support. Okay. We've got 2 pockets of funding that's coming our way. And in terms of our general approach around, we have developed a new campaign around attraction, which we hope to launch today. And it is called Be More, that's our tagline. And it features staff and their career opportunities that they've had in this trust. It focuses on the fact that we are more than just a hospital. So it talks about the opportunities in community services, in us being a research centre, opportunities in estates, and some roles that you generally may not necessarily associate with the hospital or the NHS. So that's really the angle there, and the aim is to fill some of our corporate roles like, finance, communications, and attract people who are also looking for opportunities for training, so we can use our apprenticeship level.
Yes. And I guess last but not least to say, we are in staff survey season and vaccination season. It's fair to say from a vaccination perspective, we are in a better position now than we were this time last year, but there is more work to do. Staff survey, we're pushing to get as much take up as we possibly can. So I think with that, I'll take questions really, if there's any.
Thank you, Aruna. Well, there's certainly one from Martin, because I checked the participant list and I saw his hand. So Martin, would you like to start?
Yeah, it's really a specific question, a general question, probably for Debbie. The report talks about recruiting more people to help with the mental health of staff. So I was wondering if there was any update on how that's going, particularly because I know that's very difficult in that area for the reasons partly that we were just talking about with mental health services. But then just more generally, for you or any of the exec really, I think it would be helpful just to get a feel for what the well-being issues are amongst staff, because it's very easy to sort of, make assumptions or hear things. But I think it's such a critical issue. It'd be useful just to hear what you think the key issues are and what we're doing about it. Thank you.
So, I think we've already touched on the fact one of the key areas is the psychological and mental health support, and that is an area that we are absolutely focusing on. We are recruiting at least two mental health and psychologists to the occupational health department, and that recruitment is still in train. What we've also thought to do is support people to manage through COVID. And we have set up a number of listening events with our staff counsellor, but also with the executives, because we found that staff have found it quite therapeutic to have a listening ear. So myself, Arlene, and the medical directors and the COOs have set up those sorts of sessions with staff, and they've been able to do it in a multidisciplinary way. And we have listened and put in place support, such as, delivering meals up to the ward, for example, ensuring that they have rest areas and they can have their breaks in a rotational way to use those rest areas. So there's been some simple approaches to this, but I think on the whole, there's been the coaching support, the mental health and well-being support, and the opportunity to hear from staff and for them to, feel that they've been heard.
Could I just ask, Debbie, there was, and I think, Daniel, this might have been on one of your reports, there was a budget for psychologists to specific ITU wards. Is that still in train? Do we still have that budget?
The budget, I think the budget that we talked about was to invest 150,000 in the occupational health department, and we are recruiting 2 psychologists. Okay. But there are some areas in the trust that also have their own on-site psychologists who are also supporting staff within those areas.
Okay, could I just follow up with one thing? Thanks, that's very helpful. I mean, different kind of stress and perhaps a different group of employees, but as in many organisations, you've got a lot of employees working remotely, and I know in many organisations that we hear that there's lots of stress from people because the IT isn't performing as you'd expect, both for remote people but also for people working on site. Could you let us know what that situation's like?
Is that one for Peter?
Yes, I believe that I'll hand over to Peter for that one.
I'll talk about the technology component. So, so you're right, Martin, that it can be a very stressful time, both having to juggle, for example, if people have to self-isolate or support family members, or they're in the earlier phase with shielding themselves. And what we are doing is working very closely with each kind of business unit as to sort of support them, particularly if there's a larger number who need to work off-site, is to work through how we can support them to think through how do they change the way they work when there are more people working off-site. So there are some technology solutions we have in place which for different members of staff work fine, and for others are really not very satisfactory. And so we're working very hard on looking at alternative technical solutions, but part of it is working through how do teams work together to maybe change some of their workflows to accommodate those who've got, who need good access, part of the team are on site to do that, and doing different tasks if they've got internet or other connectivity problems at home. So there's quite a lot of work that we did right in the first wave, and we increased the number of people with laptops from over about sort of 1,200 to about over 2,000, so that people can work remotely. But it is very challenging for staff, particularly if they are not necessarily particularly technology literate themselves, to be able to make some of this work. But also some of the solutions aren't as effective as they might be, in part because some of our platforms, for example, our clinical manager was never designed for a remote working environment, so that even if we use technology to facilitate that, it doesn't work very effectively at times for some people. So, which is why we're taking more of a holistic view to say, how do we support people in their context, or what work can they do effectively at home, so particularly in the team context, to change the way that maybe a team works to enable them to be as productive as they can be.
Thank you.
Thank you, Peter. And I think IT keep getting new things thrown at them to deal with almost overnight, don't they? Like the whole staff testing thing that we heard about earlier, having to find an IT solution so that we weren't inundated with slips of paper from staff and we could actually properly monitor it. And that was just an additional task that just suddenly arose and was top priority. So I do recognise that your teams are really stretched in all kinds of directions and are doing a sterling job. I can't see any other. Elizabeth, I can see you.
Hello, Gillian, thank you. Debbie and Aruna, I'm very pleased to see the report about the overseas recruitment. And of course, we are very careful which countries we recruit from and which parts of the world. I know that. I wanted to ask about it from the other point of view, which is, whilst we have been in this particular situation with COVID, have some of our overseas nurses chosen to return home? And also there will be some who would normally have gone home on holiday who of course haven't been able to. And have we put in place anything in order to help and support them in order to reach out to their families in quite far-flung places?
Can I take some of it?
I'd be very grateful, Arlene. Sorry, I was trying to read a chat question at the same time. So sorry.
That's okay. So yeah, we are careful about which countries, and we have just joined the Capital Nurse Collaborative around international recruitment, which is all done ethically. Although we have had direct applications from staff in different countries, and you know, staff are free to apply, and so, you know, we're not going to we're not going to encourage it. We will still consider the application if they meet the essential requirements. So we are continuing to do that. On the other question around the staff that we have, so we have quite a number of nurses who are from overseas, and we have, where we can, accommodated them to go and have leave and then come back and quarantine, set them up to work from home if they can do, so that they can still get to see their families. So we haven't stopped that from happening. We have facilitated it as much as we can, as long as staff let us know. We will continue to do that. So it has not come up as an issue, And, we keep our ears close to the ground through the various networks to ensure that staff are not feeling that for whatever reason they can't get to see their families or to interact with them like they would normally do. So we are supporting staff proactively to do that.
Thank you, Arlene. That's very helpful and reassuring, actually. I can't see any other hands. Could we note the report, please, from the People and Organisation Development Committee and move on to 22C, Finance and Performance Committee. Richard.
Good morning, everybody. As ever, this covers two meetings, and I'll sort of amalgamate the comments or the observations across the two meetings. First of all, in relation to performance, we've had reports on both urgent care and planned care and the progress in terms of the returning to some sort of business as usual. And in terms of urgent care, particularly the improvement in performance from triage and the time to first assessments, and also an observation that we were running at over 90% performance against our 4-hour emergency standard, although I think that was against fewer patients than might be expected. As far as planned care, I mean, this is a huge achievement, and everybody should take an enormous amount of credit for this, as certainly we were, as at the September-October discussions, running at, I think, something like 55–60% of new referrals against our pre-COVID business as usual levels. A large proportion of that were cancer patients. The implication obviously is that other routine planned care perhaps was still not returning to normal levels. Outpatients, as we've heard, running at near 100% of pre-COVID levels, and a very significant portion, some 40% of those, are by virtual appointments, which is a great achievement in terms of adapting to a new environment. There was also very good news in terms of the recovery in diagnostics. We've heard from Daniel about the CT scanner, and also in surgical admissions. So right across the board, tremendous steps forward in terms of returning to normal under our planned care. I think the one area that has been highlighted as an area for concern, but which is going through some further investigation as to perhaps a bit more diligence on the underlying list, is the 52 long waiters, which didn't seem to be reducing as quickly as one might have hoped. Therefore, more work is being done on that. In terms of finance, as people will be aware, through months 1 to 6, we've been continuing to operate on the sort of temporary financial regime of block contracts and direct reimbursement for COVID-related expenditure. But in these two meetings, and particularly the October meeting, there's a lot of focus on what happens in months 7 to 12 as that temporary regime comes to a halt, and we move to new financial envelopes, I think is the phrase that's now being used, which have been published by the NHS and basically also require an allocation around Southwest London. The latest forecasting that we discussed in October indicated a shortfall against our expected income of something in the order of about £12 million. A lot of detailed analysis and assumptions that underlie that, and clearly there are a number of moving parts. One of which was whether or not there was the potential for some additional funding which would serve to further reduce that shortfall. But I think it is worth noting that within that analysis, there are some assumptions about achieving new efficiencies, which have yet to be sort of fully bottomed out and identified. So still a big challenge for the trust as a whole, but a lot of work going into that. We've had an update obviously on capital programme, where a number of projects have fallen behind a little bit as a result of the COVID related delays. So I think the current forecast is a capital spend of about £30 million, which is a little bit behind where we might have otherwise anticipated. I guess the other two points that were discussed and sort of endorsed for submission to the board, which we're picking up a little bit later, is the 4 Trust pathology partnership in Southwest London, where in September we reviewed the core business case and endorsed that, subject to some clarification which was subsequently received around the management structure and governance arrangements. And then subsequently we had a discussion on the actual LIMS system, which is the key enabler for the proposal on the pathology. And again, that was discussed and sort of is being brought forward to the board later today. I don't think there's anything else much that I've got to add. I don't know whether anybody has any questions or whether Rakesh or Sue wanted to add any more colour to those comments.
Thank you very much indeed, Richard, for that very comprehensive report. Sue, I can see you. So anything from you? What's the position on 52-week waiters?
I think, as Richard says, it's challenged. Our two biggest issues dealing over the last, I think, 4 to 6 weeks have been a lack of available resource in terms of staffing to book the enormous number of patients that we've had to rebook back into our amended clinics. So if you remember, we rejigged the whole outpatient timetable to reflect our new way of working, and that's entailed I think what's followed on is an enormous piece of work where we actually haven't had the resource from a staffing perspective to meet the demand of the rebooking. So this week we brought in 5 additional experienced bookers who will help us get on top of that. And from the inpatient perspective, we are struggling with preoperative assessment capacity, which is due largely to shielding staff who've been off sick. So we have now a plan in place to bring in additional staff from other areas to help with that. And also aligning our theatre capacity with demand. So just because you have a theatre, it doesn't always mean that it's the right type of theatre for the patients that we need to move in. So although we've got private capacity down at Ashtead, we can't move certain lists down there. So we are constrained with the type of capacity that we've got. So we're reviewing everybody in our theatre lists who've currently been booked, making sure that we're booking in order, and that where people, if there are any short waiters that have been inadvertently booked in, how can we readjust those lists to accommodate long waiters? And Philippa and I are personally overseeing the reduction and meeting with the teams at least twice a week. We've picked off specialties and we meet with our divisional directors once a week to look at it in the round. So I'm confident we can bring it down, but it's going to be quite a long exercise. Over the next 2 months, I think we should be getting on top of it.
Sue, may I just ask a very quick supplementary on that? Because one of the questions that we raised before was whether or not there are questions around the integrity of the 52-week list itself.
Yes.
Have we managed to get to the bottom of that a little bit better?
Yes. Yes. So we have. So we've validated the patients on those lists. We're phoning them up to see whether they still want their surgery, and they're being clinically reviewed as well. And I think, sorry, just one final point is that we are working as a system. We're working with Croydon to help with our gynae waiters, and we have Mutual Aid and Kingston as well around general surgery if we need it. So that's just an important point to note.
Thank you, Sue. I think the system working has been superb in this, in relation to this particular issue, hasn't it? Pat, I saw you trying to attract my attention.
I just wanted to see whether how long we've got access to Ashtead, and is that, I mean, what proportion of our caseload we are using that hospital for?
So we have two theatres down there. We're using it for ophthalmology and some general surgery, and the surgery has to be less acute down there. They can't take some of our complex cases, but we're putting a mix down there, but a lot of our ophthalmology is going through there, as you know, as part of our hub structure. And they are trying to work with us now to help us out with some additional staffed theatre capacity to take some of our long waiting patients. And we've secured a couple of lists in November to do just that. And we have a theatre at St Ant's that we're using as well.
So is it negotiated on a monthly basis now?
No, we have it, Rakesh, remind me how long we have it to? You're shaking your head.
So we have it to current national agreement is till the end of December.
Yeah.
And the call I was on before board, I was told that they're negotiating the framework contracts, which will be out over the next 2-3 weeks. But beyond that, there's no clarity of the funding for the contracts. So we should get something, I think, understanding knows more, but that's the latest intelligence I have.
Yeah.
Thank you.
Thank you, Rakesh, and welcome. Elizabeth, you've been trying to attract my attention.
Thank you. Thanks, Sue. I wondered if the second wave has made any difference to the willingness of people to come in for planned care, Sue, and whether we had to amend anything because of that.
Not to date. We've upped our game in terms of the scripts that we use with our admin teams. So we have persuasive scripts where we can illustrate how we are offering a safe service and how we're making sure that for example, our day surgery unit is completely closed off in the same way that Swelliok is. So I think we are pretty successful at filling our lists, and that hasn't hit us just yet. My biggest worry is that if the surge continues, people will start dropping off in terms of attending for their appointments, and that may then impact on our vastly improved cancer performance. You know, that's what scuppered us last time. But we have done some work with our teams to say, you know, when people phone up, this is what you need to tell them. You don't just say, okay, we'll accept the fact that you want to cancel. We need to probe a little bit about why and provide that extra level of reassurance. So it has been problematic, but I think we're finding ways around it. And certainly our activity is going up in outpatients, and so it's, and diagnostics is improving as well.
And I suppose anecdotally, the more people who have come in and had a positive experience, the more it gets out there to people that we are open for business, and it is the right thing to do.
Yeah. Yes, and that's right, and we've linked in with community groups as well, who've got vast networks through WhatsApp and social media to try and get that message out, and we're asking our own staff to get the message out to local residents too.
Thank you, Sue. Chris, I've seen your hand.
Thank you very much. I just wondered if Sue could give us a bit more on the validation process that she was undertaking with the long waiters, bit of flesh on the bones. What was the outcome of all those phone calls and clinical reviews?
So the clinical reviews, Chris, are making sure that the patient is safe to continue to wait. And we've been undertaking these right from the outset. So when we book somebody, they're recorded as the P1, 2, 3, 4 category. So we know the urgency of the surgery. For those patients who've been waiting a long time, they would already have been categorised through that process, but we're going back over them with clinicians. So each clinician is reviewing their own patients to make sure that there is no danger in them waiting. And if there was, we would fast track them in somewhere. And then we have admin teams where we think that there is some scope for asking people whether or not they still are intending to come in for their surgery, because you can imagine in some cases, if you've waited over a year, you may well have gone and sought care elsewhere. We're going through and validating in that way and removing people if they no longer want their surgery, but only in those cases where they perhaps have gone and sought help elsewhere. And when we go through the 52-week patients who've waited over 52 weeks, we go through them line by line every week. So we do review where we're at with each patient every week.
And did you find that many patients no longer wanted to come in for surgery?
Very few, but interestingly, even those who've waited a long time. So for example, in gynecology, we're trying to move about 80 patients over to Croydon because they can operate on them within the next 4 weeks, and only half the patients will agree to go. The other half are insisting that they would rather wait than be operated on at Epsom and Helier. And no matter of persuasion, transport, all sorts of offers, and they're still reluctant to go.
Thank you very much.
Daniel, I think I've seen your hand.
Thank you. So I just wanted to clarify two things. So on the use of the private hospitals, this, to remind you all, was the government requisitioned nearly all of the private healthcare capacity in the country to help the NHS. So our local private hospital is from the Ramsay Group in Ashtead, and essentially they've made 2/3 of their hospital available to the NHS, and we have been a really good user of that capacity. So at the last count, it was over 1,500 NHS patients have been treated at the hospital in Ashtead. Where the private hospitals have not been made great use of by the NHS, the government is taking them off the list of hospitals that are available. But we have been a really good user of that capacity. So I can be pretty confident that the taxpayer has got good value for money from from us using Ramsay Ashtead well. So I'm hoping that we can continue using it for the rest of the financial year. And the framework that Rakesh spoke about will enable us to do that. And the second thing I just wanted to say was that, so Sue explained all the complexities of trying to get the planned care back again, but those complexities are about how do you in the end deliver more than 100% of business as usual, as opposed to just trying to get back to business as usual. So last week, for example, we did more outpatients in 1 week than we've done in any other week in the last 3 years, apart from 1 week. So the second highest ever. And radiology is like it's 119% of business as usual capacity. So I just wanted you to understand that what we're trying to do is make our processes do even more as opposed to just get back to business as usual.
Thank you, Daniel. That's very helpful. If there are no further points, can we note the report and move on to Sutton Health and Care and Surrey Downs Health and Care? Chris.
Thank you very much. Apologies, I can't make my video work for whatever reason, despite a couple of goes. So this will have to be verbal. So you have the report in front of you. And I just really wanted to pick out a couple of key areas from it, or several key areas really. First of all, around the surge plans, which is the capacity for both Sutton Health and Care and Surrey Downs, and particularly the community services, to cope with the second surge, which we're going through now, of COVID. So those plans have been developed very much with local partners, not handed to them as this is what it is. And particularly, I think in Sutton, where both the voluntary sector and I saw that Healthwatch are one of our attendees, Healthwatch contributing a lot to the development of those plans and contributing as to how those plans, to the support of those plans. So they're well developed now, and informal feedback, certainly in South West London, is that the plans are well developed and good and ahead of the game to a certain extent. Part of those I wanted to put in now was the involvement of community services in both sides of ensuring that flu vaccination is given to the housebound, and that will also take place when the COVID vaccination is planned. And again, this is being done as a system-wide thing, so we've had voluntary sector support and ideas as to how they can support the delivery of this mass vaccine. Not more than mass, whatever, mass plus vaccination program. Also wanted to pick out the support that's being given to staff at the present time with the development of weekly webinars which form into two parts. One is some information for staff as to what's going on in the wider world, but secondly also a questions and answers opportunity, and that's senior management are attending those with an invitation to non-exec directors of the trust to attend if they wish to, which I think is good because it shows the staff that we're all in this together. There has been, as one would expect, an increase in number of patients with COVID, which puts pressure on the staff as to how they manage that. Though I think I can report that certainly in the Sutton area, Director of Public Health says there have been cases in the community, obviously, that but that at the present time care homes are having small numbers of cases, and hopefully that will persist. Just as with the acute part of the trust, planned care is open. So the planned care services, particularly around things like diabetes and podiatry, are available to our patients across the trust areas. A big issue that's being developed is what's called the Home First Plan. This is the desire to have the concept of when patients are in hospital, one thinks of getting them home is the default position. And then if that's not good for the patient, then you move on to other things. And that's a very significant piece of work, again, with a wide range of partners, particularly the voluntary sector has been involved with that. You see on the IPR, on the board meetings, that there is the workforce in our community beds. There's data on workforce attendance there, but we do have a comprehensive performance dashboard for community services that is reported to PSQ. The three risks that we have are common across both Surrey Downs and Sutton Health and Care, and they're down to workforce vacancies, though we did recently have some very good recruitment to the Elmbridge area with community nurses. Demand and capacity, increasingly complex patients, particularly those with COVID, who require more complex care, more complex PPE for the staff, and a pressure on our bed-based capacity, particularly in the community hospitals in the Surrey Downs area. I'm very happy to take any questions and very pleased to get any comments, but perhaps if that's okay, Chair, well, I'll ask Thursday if she wants to add anything to what I've said.
Thank you, Chris. And I can see Thursday, she's shaking her head. So thank you for the very comprehensive report. It's very striking, the partnership effort and involvement that you describe, Chris, and having attended a meeting both in Surrey Downs and in Sutton, that is just so apparent and so beneficial. I can't see any hands at the moment, so if there are no points, could we note that report and move on to item 2.3 on the agenda, which is the Integrated Performance and Risk Report. And we'll go through this in the normal way. I'll ask directors to highlight anything that they particularly feel they need to highlight for the board, starting with Ruth.
Thank you. So I wanted to make 2 points actually, which Pat has already alluded to. One relates to the increase that you'll see in our HSMR rate in April, with the highest category being in patients with pneumonia. We have undertaken a deep dive into those patients and are assured and have presented to PSQ the analysis confirming that those patients represented a cohort of COVID patients who were in our beds during that April period. So that was one point. And the second point, again, which was discussed at PSQ, relates to the caesarean section rate, which was standing at 34.8%, and quite appropriately has been the subject of a deep dive at PSQ in August. So no further comments to make, but very happy to take any more specific questions.
Thank you, Ruth. I think if I go through all the directors to say that make any comments, and then I'll take any questions so that we get through this in an expeditious manner. Arlene.
Thank you, Chair. My IT is playing up, but I will. I have. So in terms of staffing, which one comes first? In terms of staffing, we continue to do well on CHPPD, the work that we have started doing on triangulating our staffing data with our patient safety quality data, and we will be taking that to PSQ in the coming months. There is nothing of great note in terms of CHPPD. We did have access to quite a number of different staff during the pandemic, and that includes nurses who were in their last year of training and were able to go and be registered, for instance. And that has now used less of those nurses like that. In terms of infection control, it is that we continued infection control measures that we always do. From an MRSA perspective, we have had no MRSA bacteremias attributed to the trust. Our C. diff levels are just a bit above the trajectory, and we are doing work on ensuring that that is monitored and we are able to get on top of any issues quite quickly. Are always investigated with root cause analyses, so we get learning from them quite quickly. Those are the major things. The report does contain the number of COVID deaths that we have had as well, which is updated daily. That's it from me.
Thank you very much indeed, Arlene. Sorry, there was, as you say, your IT was poor there, and it was a struggle to hear it all. So there may be questions as a consequence of that. So Sue, anything that you wanted to highlight?
Just a couple of points. Our cancer target, just to make everybody aware that we're back on track for September, and we have met the 62 urgent referral to treatment target for GPs. And by way of illustrating how well they are doing, I've made a note that 24 patients have waited longer than 104 days. That was down from 80, it's now 15. So we're making weekly inroads into that. We've talked elective care, we've talked about our 52-week waiters. We will continue our focus to bring those down. Diagnostic waiting times, though, again, an improvement. We're up to 78% this week. And our routine referrals are at about 60 to 70%. And urgent care, we have held above 90%. Epsom's very challenged at the moment, but I'm hoping we can still make the month. We're looking at different ways of managing Epsom with the increased number of COVID patients. But just to let everybody know that the work we're doing to improve our buildings is on track to deliver at the end of this year. So we should have, as a reminder, improved same-day emergency care space, mental health space, and improved waiting space. That's it from me, unless there's any other questions.
Well, it's a nice positive final point to hear that. Thank you, Sue. Debbie, anything you need to highlight in the report?
Yes, please. Thank you, Chair. I just want to talk about sickness absence, and again, just to reiterate that this is an area of concern and focus for us. So we're looking at this as a priority. We're working to increase the capacity in occupational health. We're ongoing with our risk assessments, and we will be undertaking surgeries with myself and my deputy to support senior managers in dealing with some really complex cases that they now have as a result of the pandemic. And then just moving on to appraisals and mandatory training. Again, just to clarify that these are areas down during the pandemic, and we only just asked people to start focusing on them, and we've entered this second surge. So hence the reason why our numbers are quite low there. And as we've talked about earlier, we're reviewing the way we are undertaking our appraisals with a new format, and we want that to be done electronically, so that's still in train. And in terms of our statutory and mandatory training during the pandemic, we've focused on the core areas that we needed to to ensure people were safe during undertaking their duties during that time. We now have the challenge of managing training whilst maintaining social distancing and all the other requirements that we need to undertake. And as a result of that, we are looking at innovative ways in which we can continue to run our core training, our StatMan training. So again, that's transformation in progress as well.
Very good to hear. Thank you, Debbie. And last but by no means least on the performance report, Rakesh.
Thank you, Chair. Just to note that in the first 6 months, as Richard had said, the financial framework meant that our expenditure and income were equal, so there was no deficit, as the first chart shows. That framework, as Richard alluded to earlier, has obviously changed in the second part of the year. And to note that in the first 6 months of the year, we spent £15.5 million on COVID-related expenditure, including £2 million on setting up CCOL, and against a very significant capital programme of £77 million. For the first 6 months, we're making very good progress against that, and I'm forecasting to spend the full amount as we sit here. And the cash holdings, you can see they are higher than planned, but we understand the underlying reasons for it. And importantly, as I've said in past board meetings, we continue to pay our suppliers, especially the local and smaller suppliers, within 30 days and hit and we're doing that at 94% of the time. That's it. Thank you, Gillian.
Thank you very much indeed, Rakesh. That all sounds good to me. So I can't see any questions of any of our executive colleagues in the form, the kind of form that it shows on Zoom. So if that is the case, could I please ask the board to note the report so that we can move on to the corporate risk register? Peter, that's for you.
Thank you, Chair. So a number of the key components in the corporate risk register have been touched on earlier in the discussions today or at the board subcommittees, for example, around the oxygen supply or around our CAMS patients attending, as well as the broader arrangements about supporting both patients and staff in relation to COVID. And as we've just heard, around the financials, both for where we've got to, but for the rest of the year. So all of the risk register, corporate risk register, has been through the relevant subcommittees over the last 2 months. There is, as always, there is more work to do to ensure that we're making the right linkages with the divisions. So that's currently underway. And we are then also refreshing any of the language that's in the detail of the corporate risk. But I think the headline risks are the ones that the organisation is strategically managing.
Thank you, Peter. Very helpful. I can't see anybody indicating on this either. We're invited to endorse the proposed changes to the risks within the register, recognising that they're evolving rapidly, particularly with COVID. Everyone happy to endorse that? I can see some nods, so I'm taking those as assent. Thank you, colleagues. That takes us on then to item 2.4 and the Never event report. Ruth, you're going to introduce this.
Thank you very much. So this report is to inform the board and the public of 2 Never events that occurred in May under the category of a patient unintentionally being connected to air rather than oxygen. I should also add that there was a further Never event in the same category which occurred in July, which remains under investigation. Both incidents were no harm incidents and occurred in the acute peak of the COVID pandemic relating to patients with COVID. I should also like to draw your attention to the preliminary findings from the incident investigation, which are described here. This is a complex, I think, set of issues to visualise, but in essence, in one case, the airflow meter had not been removed from the wall port after its use. And whilst it had the requisite safety flap in place, the staff did not realise they attached the patient to air as opposed to oxygen. In the second incident, it was during the emergency intubation of the patient, and it was not recognised that the oxygen port in use was attached to the CPAP machine, and the airflow meter in use at that time did not have a safety valve present. So in response to those two incidents, we have refreshed our approach and our learning in relation to a patient safety alert that emerged in 2016. We have reinstated day-to-day walkabouts and audits to ensure that airflow meters are being used appropriately. This has been the subject of newsletter of the week. There has been a very wide cascade of the imperative to ensure that patients who do not require airflow meters to be in place, if they're not receiving nebulized treatment through air, they should be removed. And this approach has been rolled out across the whole organisation in order to mitigate further risk to our patients. So I will pause there and happy to take any questions.
Thank you very much indeed, Ruth. I can see Pat's hand, physical hand, as opposed to an electronic one. Pat.
Thank you, Ruth. Obviously, we heard the report and the results of investigations on these two. The third one, which we haven't yet got the report on, obviously you will have some information about that. And can I ask, was there anything anything more that we could have done after these two incidents that might have prevented the third one? I mean, is there any learning that we could have applied?
I think the learning and the plan that was developed after the first two was absolutely appropriate, but it was in the process of being rolled out at the time of the third event. And this is all about reminding staff of something which they've been aware of for years, but it's about refreshing staff's memory and ensuring that in all the changes that have taken place with COVID, they are reminded of the imperative to remove flow meters when not in use.
Thank you, Ruth. That's very helpful. I think we need to remind ourselves of the atmosphere at the time that these Never events took place, with staff dealing with this huge surge in COVID patients. Aruna, I think you've indicated as well. Can't
Yes,
see you now.
yes.
You were on my screen and you've disappeared, but you did indicate.
Yes, can you see me now?
I can't, but I can hear you loud and clear.
It's interesting. Sorry, my camera's on, but
No. I don't think it's your fault at all. I just think there's been an arrangement of the 9 people I can see.
We can see you, Aruna.
All right. So the question I had was, it's very useful to know, Ruth, that you are doing walkabouts and you have reiterated to staff, in terms of the use of the airports and the airflow meters. In the report, it says divisional risk assessments have been undertaken and management of medical air and clinical air areas is being monitored through harm-free care audit. Where do these audits go, and could we get sight of it?
So absolutely, Arlene may want to come in at this point because they go up through Arlene's nursing route through the weekly meetings she has with the senior nursing team, and then on to nursing and midwifery executive committee. Is that correct, Arlene?
Yes, that is correct. And they are included in part of the monthly audit that the matrons do. So monthly, the matrons do audits around all other key performance indicators for patient safety, including falls, pressure ulcers, what you would expect. We've added on there the medical air issues so that it is audited monthly. And as Ruth says, we monitor those audit, we highlight those at our Nursing and Midwifery Executive Committee, which is held monthly. The data from the harm-free audit, Aruna, forms the basis for the heat map that does come to PSQ as well. So that is the same data that you see on there. And for the next month, we will include the harm-free audit. We will include this medical gases, medical air audit as a separate column, but it is all on there. And it's stored centrally on a drive that all of the senior nursing teams and the quality teams have access to.
Okay.
I think Arlene and Ruth, when the third incident comes back to PSQ with the investigation report, we will need to bring all this together and look at it holistically to see that we have covered all of the things that we should. Thank you.
Thank you, Pat. You made the point that I was going to make, actually. Clearly, Patient Quality Safety Committee will be scrutinising this very carefully, and it will come back to board as appropriate. Just checking my participant list to see if I've got any other hands. No, there's nobody else indicated. So we're asked to note the report, clearly in the context of the discussion we've just had, and the work that has been described to us and will be carefully monitored by patient safety and quality and back to us as appropriate. Thank you, colleagues. If we can move on then to the mortality reporting, item 2.5. Ruth, this is you as well, I think.
It is me. I'll provide a very high-level summary because it's quite a detailed paper. In essence, the key points I want to convey from this Q2 report is that we continue to have good performance with undertaking structured judgment reviews, with 92% having been undertaken during the period under question, and a consistent high overall rating of care with no major changes in trends. We continue to learn from the SJRs in relation to sepsis and PTEC documentation, and also a feedback that there has been in this quarter relates to the imperative to involve our end-of-life care team earlier in the care of some patients, and that particularly again related to patients with COVID. The main thing I think that is new in this report is the implementation of the medical examiner system, which came into place in July and is progressing very well. They are reviewing over 80% of deaths in remit at the moment, and PSQ have asked that a separate report is collated from the medical examiners so that the committee are cited on their function and the learning from the service. So in essence, that is a summary of the report, and happy to take specific questions.
Thank you very much indeed, Ruth. I'm so pleased to see that the medical examiner system is settling in so well. I know it'll be of enormous benefit to patients as well as to staff in the trust. Pat.
Ruth, in light of the second surge and the fact that during the first round of COVID, there were some issues about making sure the palliative care team were properly involved. Have we sort of sharpened that up so that they will be properly called upon as appropriate?
Yes, so the palliative care team and the medical teams have liaised to remind the medical teams of the importance of that early involvement. But obviously there may be capacity constraints. So again, work on how they prioritise their involvement in care has also been undertaken.
That's very helpful. Thank you, Ruth. I can't see anybody else indicating. So we're asked to note this report, and colleagues, if we will do that and then move on to item 2.6, the flu update report. Debbie, this is yours.
Yes, thank you, Chair. The paper that is attached is to brief the board on the uptake of the flu vaccination programme in line with the best practice management checklist, which is attached at Appendix A. So I'll take the paper as read, but I just want to draw out some key points. It is our ambition as an organisation to achieve the 100% target, which has been set out by NHS England. And our approach this year is that we've trained more than 100 peer vaccinators to support the programme as well. In the pack, I've highlighted the vaccine uptake as at the 5th of November, but I'd like to give an update of where we are as now. So for now, our overall trust uptake is 59%, and we have vaccinated 60% of our clinical frontline staff. I think, you know, it has been challenging this year because we've had to adapt our program in line with the changes as a result of the pandemic. But despite these changes, I think we're making some good progress. We've introduced some innovative approaches this year, which has included the online form, which has helped us improve our governance and the data collection. And we've also introduced a drive-through clinic, mirroring the approach that we're doing with staff swabbing at the Malvern Centre. So I'll stop there, and if there are any questions, I'm happy to take them.
I think you covered the obvious one, Debbie, which is what's today's percentage? I'll just check. I can't. Oh, Pat's waving at me. So Pat, if you'd like to ask your question while I check the list.
Debbie, I just wondered. Sorry, I turned it off again. Is the rate of declines up or down on last year? Can you tell me?
Oh, I haven't looked at that, but that's something I can go back and look at and come back to you. I think the thing we found challenging is the fact that we do have a number of people who may be working from home and may have had their vaccination with their GP, and the challenge is around capturing that information. I think that's one of the things we found challenging this year.
Okay.
But check around the declinations.
I just think, you know, if it's going up, we will need to look at that. That's all.
I think the other thing we need people to understand in relation to the proposed COVID vaccination is the need to have had the flu vaccination well in advance. I can't remember whether it's 3 or 4 weeks, but there is a time period. And also, I think people need to understand that if you get COVID and flu, it's a very, very nasty business.
Arlene, do you have your hand up?
Oh, thank you, Peter. I can't see.
Sorry, I was just going to add that I think Debbie will get the declination numbers, but anecdotally on the ground, because of the method that we're using with the peer vaccinators, where staff on the wards are doing it with their colleagues, we have had uptake from some staff who've never had it before, because they didn't think that they could get it, or for several reasons. But the fact that it's being delivered close to them by a colleague that they know and trust has encouraged some people who traditionally haven't had it to have it this year.
That's really important to know, yes, and good to hear. That's be good to have an update on that when the process is finished.
Right, thank you, Debbie and Arlene. If we can note that update report and move on to item 3.1, the update report from the Audit Committee. Elizabeth.
Thank you, Gillian. Well, we met in September, and as you can see from the paper, we required substantial assurance before we approved the debt write-off of £2.4 million. I really want to reiterate once again that this amount was very old debt, aged debt, and that it had been, in the accounting jargon, fully provided for, which means that there is no impact on the income and expenditure account this year. However, as you can understand, for something of this magnitude, we did require a great deal of supporting documentation before we approved it, and we were fully satisfied on that. From the external audit, we welcomed to the trust the new partner from KPMG, and who is taking over with effect from the audit this year. And we spent quite a bit of time talking about the new approach which there is going to be to what is colloquially called the value for money audit, also the use of resources audit. In previous years, as colleagues will know, the opinion which the external auditors are required to give has been very binary. you either satisfied the Treasury's definition of value for money or you didn't. And it was a very, very high bar to get over. Now, KPMG, our external auditors, will be required to make a narrative report. And the reason why we have said that we have only got moderate assurance around this is that at the moment, none of us have any idea what the parameters of that narrative report will be. And so we're waiting for further information from KPMG. I just briefly want to mention the internal audit report on the e-rostering system, where we received moderate assurance on the controls in place, but only limited assurance on their effectiveness. And I know, I mean, we were very pleased that Debbie came to the committee, and I know that this is a historic report now, that Debbie has taken it on board. There was a reference in Aruna's pod report that it had been discussed at pod. There had been some changes in the people responsible for this system, and we will be keeping an eye to make sure that the new recommendations are implemented going forward. The rest of the meeting, we received some of our usual reports, particularly around cybersecurity, which in this time when we are relying more and more on our IT is very important. And it was a very productive and interesting meeting. Thank you, Gillian.
Thank you very much indeed, Elizabeth. That's very comprehensive and helpful. Thank you. I'm just checking to see if there's any questions in the chat room, and there aren't. So if there are no points that people want to raise on this, could we note the report, please?
Gillian, sorry, Gillian, Aruna is waving her hand.
Oh, so I'm so sorry. I'm so sorry, Aruna. I can't see you, and I was busy checking the participant list. But please, the floor is yours.
Just very quickly to reassure Audit Committee that we did discuss the e-rostering, and I think Debbie has now a crack team working on processes and systems in HR, and certainly I'm seeing huge differences in the quality of information that we receive. So I just want to assure the committee that I think even if you looked at the IPR as an enhanced version of the metrics, the people metrics. So we're on that journey.
Yeah, thanks very much, Aruna. Really helpful.
Very good to hear. Thank you. So I can't see any other hands, so we will note that report, and it takes us on to item 3.2, the Infection Prevention and Control Annual Report. Arlene.
Thank you. Thank you, Chair. So the report, I think, of note is that the report does cover the period just up to where COVID was really escalating. So we have then been doing quite a few updates to PSQ and to the board around COVID anyway. So while this report doesn't extensively cover COVID, we have been ensuring that we update the board and the several subcommittees on COVID during the time. The report covers April last year to March this year. The significant events have been the trust entering into partnership with Surrey Downs Health and Care and Sutton Health and Care, and also with Moulbridge Practice. And there was quite significant bit of work that went into aligning policies to ensure that all of the policies were totally aligned across the system, both acute and community. In terms of the MRSA, which is what we're required to report on, we had 8 cases of MRSA last year, with only 1 attributed to the trust. We had a full investigation done into that 1 case, and there were very little in terms of learning. The patient had a skin condition, and therefore it was considered to be unavoidable. We had 45 cases of C. diff recorded across the organization last year, with 30 attributed to the trust, which is below the trajectory of 52. So the upper limit for the organization was set at 52, and we had 30 cases. And in only one case was non-compliance with trust antimicrobial processes highlighted, and one was a cross-contamination. So we will continue again to monitor and to investigate those as they happen, to ensure that we put mitigations in place to prevent any happening. We had one death from C. diff, and again, we reported that appropriately, and no lapses in care were identified. We continue to do hand hygiene audits, which we report monthly as part of the IPR. Importantly, the monthly audits also include our community hospitals, so hand hygiene compliance in particular, and now the PPE compliance is, those audits are conducted monthly and reported up to the Nursing and Midwifery Exec Committee and then PSQ to board. I think one of the things I do need to highlight is that those hand hygiene audits are always a point in time, so they're point prevalence, and I ensure that we report what is found on the day, and then we take action. And in some cases, wards will be required to do daily audits until compliance is achieved and within the standard that we require. So that is an ongoing process. And I'm quite happy to take any questions because the full report is there.
Thank you very much indeed, Arlene. It was indeed a full report, I think, with some notable successes. I'm not sure it's appropriate to say that when you've still got a number of like on C. diff, that's a success, but it was well below the target, wasn't it? And I know that a lot of places do struggle with C. diff. So I was very pleased to read some of those statistics in the report. I cannot see anybody got any hands up, but I think this has also been through Patient Safety Quality Committee, so people have already had an opportunity. So if there aren't any particular points, can I ask people to note that report? Thank you. Which takes us on to item 4.1, contracts awarded over 50,000. Rakesh.
Sorry, Chair, I was on mute. So these have been discussed at committee, and just for noting here, really, or any questions?
Thank you, Rakesh. I suspect not, but let me just check. I can't see any hands, electronic or otherwise. So if we could note that, please. And then the use of the trust seal, Trevor?
Hi, Julian. These are for to note as well. They've been previously approved at trust boards, so just for noting.
Indeed, many thanks. And I'm pretty sure there won't be any questions, and so we can note that as well. Thank you, colleagues. So we move on to item 5, any other business. We actually do have a couple of items of any other business. The first relates to a paper that was put round late about establishing diagnostic imaging networks. I don't know whether anybody wants to say anything about this paper. I think the decision asked of us is quite an obvious one, but I don't want to steal anybody's thunder if somebody needs to say anything.
So I think it's worth saying we already have a diagnostic network in South West London, and all the providers who the system want us to join are already members of it. So so as you say, this isn't very difficult to agree to.
It's not, and Daniel and I actually had an exchange about whether we should put it to board given our situation, but I went into governance mode and said, yes, we've been asked to by NHS-IE, so we had to. So I'm sure colleagues will make the necessary agreement on that. And then that takes me to the second item of any other business, which is something that I'm very sad really to have to talk about, and that is that it's Pat's last public board meeting, and she clearly had forgotten that I was going to do anything like this, or chosen not to remember. Pat, you have been a member of the Trust Board for 10 years now, and Vice Chairman of the board as well. I think as importantly, you have been a friend and wise counsel to members of the board over all those years, members of the board who've come and gone. I'm one of the newest members, and your support to me as a new chairman of ESTH has been superb. I can always rely on you to give me wise advice. And I think your kindness and consideration for others are other characteristics that we've all admired and benefited from. And it's very difficult to imagine the board without you, actually. It's something that I prefer not to imagine, but I have to face the realities of a calendar which is moving us resolutely towards the 31st of December. I worked once for a chief executive many, many years ago now, who at my leaving speech said, to my considerable irritation, I have to say, that, well, you know, Gillian's done a great job, but the waters quickly close over. I mean, really, what a thing to say. I want to say in relation to you, Pat, that I don't believe the waters will close over. Clearly, the board will have to get on with its job without you. But I think you will leave an indelible mark on ESTH. And I know an indelible mark on the very many people whom you've dealt with, whom you've assisted, whom you've given wise advice to, who you've asked penetrating and relevant questions, but always gently and always in the best interests of the trust. So I know I speak on behalf of all my colleagues in saying the most enormous thank you for all that you've done and how much we will miss you. And a particular irritation is that COVID means I'm still struggling to find a suitable way that we can mark our respect and thanks, Pat, and wish you the very best. So I'm waiting for the announcement on the of what will happen after the 3rd of December, and living in hope that we'll be able to have some kind of party. But we may have to invent a virtual party, who knows? But that's in my pending tray. Pat, you won't get away without saying something back. So thank you again, and over to you.
Well, thank you very much. Yes, okay. I'm really proud to have been associated with the Trust for the 10 years that I have been doing so. And it's been a real pleasure, and I've learned a huge amount, and I've met some fantastic people. And I've, really been grateful to have been able to make a small contribution to all the many, many successes that I've seen over the 10 years, because it really has been quite a journey. Just a month after I was appointed, we were going to be demerged, and St Helier was going to join St George's, and Epsom was going to, well, who knows, but yes, anyway, we've moved on from there, and I'm so pleased that we are where we are. I think everybody should be so proud of what has been achieved. And I'd like to thank everybody for their friendship and for supporting me to learn and to, I hope, contribute to the Trust and to the NHS, in which I believe devotedly. I have a public sector background, and I think there are many, many things that the public sector does brilliantly. And I've seen many of those happening in the Trust. So I think the only thank you I would want is to be invited to the opening of the new hospital in 2025. So please don't forget, because I certainly won't. And I don't know what I'm going to do from January, but I'll have to find something. So thank you, everybody, very much.
Thank you, Pat. And you will most certainly, there's a lot of virtual clapping going on. I hope you can see quite a lot of it. you will most certainly be invited to the opening of the new hospital, as will Lawrence, of course, my predecessor, because both of you did so much for the Trust. So thank you for that, and thank you, colleagues, for your virtual clapping. It's amazing the new skills that we've learnt over the last few months. We're asked to note the date of the next meeting, which is 9:30 on the Friday the 8th of January. And that closes the meeting, but we have a written question which has been submitted, and I'm going to ask Peter if he would read the question and the answer, if he doesn't mind. Is that okay, Peter?
That's fine. So we had one submitted question in advance from Mr. Lower-Hendren, and so I'll read the question first. So the latest information is that St Helier recorded 44% COVID cases last week, with Liverpool City, which had the highest infection rate, but the Liverpool University Hospital had only 27% COVID cases. I'm led to believe Croydon Hospital has taken a drastic step by creating a mini hospital within its compound to segregate patients undergoing routine operations. Patients are also expected to quarantine for 7 to 14 days and are tested 3 days before the surgery. Also, staff are not allowed to enter the main hospital and the outpatient day clinic, which is for COVID patients, for 12 hours and are tested. So will St Helier and Epsom follow suit to reduce this infection rate? So I'll just read out our answer. As of the 12th of November, the Trust was caring for 82 patients with confirmed COVID-19. This accounts for 14% of our inpatient capacity. It is often unclear whether a patient with COVID acquired the infection in the healthcare setting or whether the patient already had the infection at the point of admission but was asymptomatic on presentation. The overall rates for the last 3 months show Epsom at 12% and St Helier at 21% of its COVID cases meeting the criterion for being a nosocomial infection. That's those infections that have been acquired by a patient from their interaction with healthcare. National data on nosocomial COVID-19 cases shows a range of between 10 and 25%. In line with national guidance, the Trust is providing a full range of elective and outpatient services and has put in place a number of measures to minimise potential harm to patients during the COVID-19 pandemic. We have taken the same approach as Croydon in segregating out most of our planned care services. So, for example, both the South West London Orthopaedic Centre and day surgery units at Epsom and St Helier hospitals have their own discrete entrances separate from the rest of the hospital. We are also making extensive use of our local private hospital, Ramsey Ashted, for undertaking NHS activity, and this site does not care for emergency patients. We have implemented the national guidance on self-isolation and testing for patients coming in for surgery.
Thank you very much indeed, Peter. And that was the only question we had from the public. So that draws this part of our proceedings to a close. Thank you very much for members of the public who've been participating electronically, and for colleagues who are involved in the next meeting, and that will be at 12:30. So thank you all very much indeed. Bye-bye.
Thank you.